Welcome back. In Part 1, we were beginning to discuss associations between patient outcome expectations, adherence, and treatment results. We are now going to continue that discussion and explore some behavioral theories to give us a better understanding of factors that affect patient-client decision-making and willingness to actively participate in recommendations that are made by the physical therapist and physical therapist assistant. Barron, Moffat, and Porter found that patient expectations are directly related to rates of adherence and the degree of recovery in physical therapy. We are going to consider 4 types of patient expectations. Ideal expectations are based on the patient's preferred outcome. For instance, we may be working with an older adult with lasting balance impairments due to an underlying neurological condition. To reduce fall risk, our plan of care may include progression from the use of a rolling walker to the use of a single-axis cane for safe, independent ambulation. The patient's ideal expectation may instead be independent ambulation without an assistive device. This is something that should be discussed using objective measures to support the PT and PTA's recommendations. The patient may also have predicted expectations. For instance, if you are working with someone who has had a repeated episode of the same illness or injury, he or she may base her expectations of recovery on that prior incidence, even though circumstances or approaches to treatment may have changed. Predicted expectations can also be shaped by observing the experience of others. Let me give you an example from my own clinical practice. I'm a wound care specialist. A few years back, I was working with a gentleman who had a partial thickness diabetic foot ulcer. Based on the initial evaluation and consideration of his young age, access to medical care, and early intervention, I anticipated that the wound would heal relatively quickly with little, if any, complications. Instead, 8 months later, the patient developed osteomyelitis with the threat of sepsis, and he actually needed a below-knee amputation. Throughout the episode of care, the patient was notoriously non-compliant. His medication and nutritional adherence was nearly non-existent. He did not change his dressing, and he continued to walk barefoot while full weight bearing, despite the obvious risk of infection. When the patient was later asked about his behavior, this gentleman reported that shortly after he'd been diagnosed with diabetes, he quote-unquote knew that he would become an amputee because something similar had happened to his grandfather, father, and brother, who all had diabetes and all had previously developed foot ulcers. I do not know the situation surrounding his family members, but I still firmly believe that this man's leg could have been saved if patient education could have successfully changed his outcome expectations regarding the benefits of appropriate wound management. Normative patient expectations are based on ideas of what, quote-unquote, should happen. For example, if a patient believes that people with herniated discs should have back surgery, then it may be challenging to obtain the best outcomes with physical therapy, unless these expected norms can be changed through patient education. The last type of patient expectation is unformed, meaning that the patient is either unwilling or unable to describe his or her expectations regarding physical therapy. This can sometimes happen following acute onset of a serious illness or injury, where the person doesn't have any knowledge regarding prognosis or possible recovery. In these types of circumstances, education by the PT and PTA can be very instrumental in restoring hope and engaging the patient to actively participate in his or her own care. When I gave the example of the gentleman with a diabetic foot ulcer, I used 2 terms to describe his lack of engagement: compliance and adherence. Are these 2 words interchangeable, or are there aspects of meaning that we should consider? The World Health Organization defines adherence as the extent to which a person's behavior corresponds with agreed recommendations from a healthcare provider. The difference between compliance and adherence basically centers around the phrase, agreed recommendations. Adherence is the result of a participatory process where the patient and healthcare provider discuss possibilities and agree upon the proper course of action. Compliance is far more passive. In situations involving compliance, the healthcare provider makes recommendations based solely on his or her own knowledge and expertise without soliciting feedback or input from the patient. Despite how negative this sounds, there might be a few emergency circumstances where it is warranted. Since it is unlikely that any of these emergency circumstances are a routine component of physical therapy evaluation and treatment, we will continue to use the term adherence to remind ourselves of the importance of partnering with our patients to ensure that recommendations and interventions match the patient's goals and expectations. Earlier, we reviewed challenges to patient education within the practice environment. Let's take this a step further by considering some of the barriers to adherence. As previously mentioned, lack of understanding is rarely the primary reason for decreased adherence, but it is possible that the patient has misunderstood or forgotten your instructions. Therefore, it is important to review and reinforce patient education through follow-up and the use of supplemental materials like handouts and videos. Sometimes, the lack of follow-up can lead to decreased patient motivation. Positive feedback encourages adherence and provides the opportunity to modify treatment approaches, including progression. Most PTs and PTAs agree that the top reasons patients report non-adherence with home exercises and other treatment recommendations is lack of time. If our recommendations are not compatible with the patient's daily routine or personal circumstances, the likelihood of adherence is low. This is not to suggest that changes in routine cannot be negotiated, but feasibility and alternatives should be considered through open discussion with the patient. Finally, referring back to patient expectations, it is essential that the PT, PTA, and patient engage in communication that allows the patient to appreciate the relevance of the clinician's recommendations with respect to his or her own individual goals for rehabilitation. Physiological and psychological factors can pose additional barriers to adherence. This would include factors such as pain level, fatigue, mood, outcome expectations, and locus of control. As Dr. Miller, one of the founders of motivational interviewing, once said, quote, "It takes two people not to cooperate," end quote. We must remember that non-adherence frequently occurs when the patient and practitioner are pursuing different sets of goals. This brings us to another very important point. What is the role of the PT and PTA when it comes to patient rehabilitation? Is it our responsibility to fix the problem, or are we instead striving to help our patients to fix the problem themselves? When we think about the effects of physical impairments and disabilities on the lives of our patients, we should consider how many changes occur that can lead to patient disempowerment. Physical therapy promotes patient independence by fostering resilience, recovery, and, if necessary, adjustment to disability. There are so many changes that can accompany physical impairments, including changes in the patient's personal roles and identity. Changes in functional abilities can lead to changes in the patient's family roles and a decreased ability to pursue one's occupation, and also a decreased ability to engage in social activities. Even with a relatively minor or temporary injury, like an ankle sprain, there are disruptions in daily routines, the need for medical visits, medications, home exercises, and many other interventions. Stress from the illness or the injury can accumulate, along with limited opportunity to engage in leisure time activities that would normally assist with coping. Each of these factors can result in someone feeling a loss of control and independence. Patient empowerment through effective education can help address these factors. To understand the full impact of illness or injury, PTs and PTAs can often use models of disablement, such as the ICF model. These biopsychosocial models represent a shift from the traditional medical framework and a willingness to consider the impact of the environment and personal factors on the patient's ability to engage in activities and participate in their usual roles. Patient empowerment is a function of a collaborative versus authoritative approach to education and management. This collaborative approach conveys respect for patient autonomy through shared decision-making. It enhances treatment outcomes by fostering intrinsic motivation, a key component of lasting behavioral change and adherence. In addition to improving adherence and enhancing treatment outcomes, approaches to patient management that incorporate empowerment contribute to increased patient satisfaction and decreased litigation risk. It represents the difference between patients having something done to them versus having something done with them. Motivational interviewing is designed to empower patients to initiate changes in their own behavior. The theoretical basis for motivational interviewing centers on our ability to understand reasons for non-adherence and factors that are involved in behavioral decision-making. Some of the most basic theories involving human behavior involve stimulus response. This is a type of theory that is used to describe classical conditioning or learning by repeatedly pairing a stimulus with a desired behavior. Pavlov famously used this technique by pairing the sound of a bell with feeding time in dogs, leading to a response where eventually the dogs would salivate when the bell sounded, even in the absence of food. While this theory might explain certain simple behaviors, it has been criticized for its simplistic view of human behavior because it fails to account for the influence of reasoning and logical thought. Value-expectancy theories postulate that people's behavioral choices are a result of the expected outcomes of the behavior and the perceived value of the outcome. For example, a patient with back pain may initially seek physical therapy in hopes of alleviating discomfort and being able to resume their normal activities. The perceived value of the outcome is high because until the pain is alleviated, the patient may not be able to work and generate income. During the episode of care, the PT and the PTA will likely show this patient a series of home exercises. If the exercises cause temporary muscle soreness, and this is not explained to the patient in advance, the patient might think that he is making his condition worse. Adherence to the home exercise program would then be problematic. To avoid discrepancies between patient values, expected outcomes, and the recommended behavior, it is important for the patient and the clinician to openly communicate. Examples of value expectancy theories include the health belief model, social cognitive theory, and the theory of reasoned action. We will consider each of these separately, recognizing that the features of these theories often overlap. The health belief model was originally developed in the 1950s to help healthcare providers and public health officials understand people's attitudes and choices regarding preventive health care. It has since been expanded to include additional short and long-term behaviors, such as immunization, breast cancer screenings, tobacco cessation, and weight management. Basically, the health belief model states that people will act when the perceived value of an expected outcome outweighs its anticipated costs. These perceptions are shaped by several key considerations: perceived susceptibility, perceived severity, perceived benefits, and perceived barriers. Perceived susceptibility refers to a personal risk assessment. Risk is weighed against the patient's assessment regarding the severity of the health threat. The patient will decide whether to follow certain recommendations based on decisional balance, where perceived difficulties in taking action are compared with the potential benefits. Adherence can be enhanced by cues to action or gentle reminders that prompt the health-related behavior. These reminders could include personal triggers such as pain or signs of illness. Positive cues to action can also be effective. For example, a patient may be inspired to change his or her own behavior after seeing someone else lose weight through better eating habits, or someone enjoy better levels of fitness after beginning a new exercise program. The final determinant of behavior is self-efficacy, or confidence in one's own ability to take action and successfully achieve the intended outcome. Self-efficacy is also a component of social cognitive theory. In addition to confidence in the ability to carry out a certain behavior, social cognitive theory states that patients' choices are affected by outcome expectations or perceptions about the likelihood of results that might be produced by the behavior. Outcome expectancies are a slightly different component, related to the value placed on the intended results. For instance, a patient may really want to quit smoking because she feels it is important in reducing her risk of lung cancer. This would indicate a high outcome expectancy. However, the same person may feel that her chances of successfully quitting are very small, involving low outcome expectations. Reciprocal determinism refers to environmental influences that shape behaviors. An example might be the number of fast food restaurants versus healthy food options available to someone striving to improve their nutritional intake. Modeling involves observing and learning from the behavior of other people, based on the way they manage challenges and whether they achieve success. Modeling is also one of the ways children learn healthy behaviors from parents and grandparents. It also helps explain why group exercises or the buddy system can help encourage exercise adherence and increase physical activity. Self-efficacy is a really important concept. It is a component of multiple behavioral theories, including the health belief model, social cognitive theory, and the theory of reasoned action and planned behavior. As previously mentioned, self-efficacy can be defined as, quote, the conviction that one can successfully execute the behavior required to produce the desired outcomes, end quote. Decreased self-efficacy often occurs when people repeatedly try to change a chronic health behavior. Examples would include people who have unsuccessfully tried to lose weight or quit smoking. Each time the person tries and fails, he or she loses confidence and gathers so-called evidence of the inability to change the problem. Physical therapists and other types of healthcare providers can measure or assess self-efficacy using objective scales or patient questionnaires. This slide shows a link to the Medical University of South Carolina Department of Family Medicine. Their website contains copies of several instruments, including the 10-item Generalized Self-Efficacy Scale, along with more condition-specific measurement tools, such as the Arthritis Self-Efficacy Scale and the Self-Efficacy for Exercise Scale. Use of these scales for baseline assessment can help tailor interventions to promote increased confidence and enhanced likelihood of successful behavioral change in patients with low self-efficacy. The scales can also be used to measure changes in self-efficacy following interventions such as motivational interviewing. Since the two main components of behavioral decision-making described by the social cognitive theory are so similar, let's take a look at another example. Have you ever purchased a lottery ticket? Statistically speaking, you must have realized that your chances of winning millions of dollars was very, very small. Therefore, you had low outcome expectations. That is, you realized that the likelihood of winning the lottery wasn't very great. However, many of us are still willing to spend $1 or $2 for the chance of hitting it big. Our outcome expectancies, or the value placed on being a lottery winner, is high. The last value expectancy theory we will consider is the theory of reasoned action. According to this theory, intention is the best predictor of behavior. Intention to act is dependent on our attitudes towards a certain behavior, subjective norms, and our perceived control over the action and its outcomes. Perceived control is very similar to self-efficacy. Behavioral attitudes are usually formed based on the perceived value of the action or outcome. This brings us back to outcome expectations and outcome expectancies. While having a positive attitude can often be beneficial, there are times when unrealistic optimism can result in underestimating personal risk. For instance, if someone is overweight, sedentary, and has a poor diet, but no family history of metabolic disease, he or she may downplay the risks despite strong evidence that links these behaviors to increased likelihood of diabetes. Another concept that should be considered is locus of control. Locus of control is very similar to self-efficacy. Someone with an internal locus of control believes that outcomes are largely influenced by personal actions. By contrast, someone with an external locus of control is more likely to attribute outcomes to things that are determined by the environment and/or the actions of other people. For instance, someone with hypertension and an internal locus of control may feel empowered to change the outcome by starting an exercise program and/or reducing sodium intake. By contrast, a person with an external locus of control may blame their hypertension on work stresses or home life, or a physician who hasn't prescribed the proper medication. It is important to remember that locus of control is not a fixed trait, and it can vary within the same individual depending on the target behavior or desired outcome. Some other types of extrinsic controls would include the patient's perceptions that health outcomes are determined by powerful others, those other people being the physician, the nurse, the physical therapist, or the physical therapist assistant. For example, a patient may be dissatisfied with the results of physical therapy treatment and attribute this to the lack of skill on the part of the PT or PTA, rather than their own low adherence to home exercise programs and other aspects of patient education. Other patients might blame genetics for a certain outcome. Examples would include patients who feel as though they are unable to successfully control their weight because everyone in their family is obese. Fate or chance could also play a role, like people who say things like, "I always have bad luck," or "the cards are stacked against me." You can probably think of examples of these types of issues based on your own clinical experiences. Another factor that can inspire action is the use of rewards. Again, the type of reward that inspires action may partly depend on the individual and partly on the type of the behavior in question. Intrinsic rewards are intangible. Their worth is determined by someone's individual values and the things they feel are most important, like a sense of personal satisfaction or accomplishment that comes from working hard and doing a good job. Extrinsic or external rewards are tangible and can include things like ribbons or trophies, as well as measurable results like the number of miles somebody is able to run or how many pounds they can bench press. Using yourself as an example, think about the last challenge you faced and the type of reward that inspired you to act. In many circumstances, people who value intrinsic rewards tend to be intrinsically motivated, while those who favor external rewards are extrinsically motivated. According to self-determination theory, every personal action is inspired by a mix of intrinsic and extrinsic motivation. Neither is better or superior to the other, but understanding what increases the willingness to engage in a certain behavior is very helpful in promoting successful change. Patients can be encouraged to reflect on their own motivation, thereby promoting increased self-awareness. This also enables patients to plan a course of action, including the use of self-monitoring and periodic rewards for engaging in healthy behaviors. Even when assistance is needed to achieve a certain outcome, patients can exercise autonomy by seeking and accepting necessary assistance from others. An example would be a patient who wants to quit smoking and asks the physician for advice about nicotine replacement therapy to reduce the likelihood of withdrawal. Patients who self-refer to physical therapy through direct access are also choosing to be autonomously dependent. Thinking about our own behaviors, we see that motivation levels tend to fluctuate. Let's consider New Year's resolutions. The first few weeks of January, the gym is often crowded with people who have good intentions and high levels of motivation. This tends to decrease as time continues. Too much chocolate at Valentine's Day can cause another wave of increased motivation, which again starts to decrease until people start worrying about bathing suit season. Another important component of self-determination is that there isn't one single factor responsible for our behavioral intentions. The good news is that humans seem to have an innate tendency towards personal growth and psychological development. When the outcome is important enough, this innate tendency encourages us to keep trying until we experience success. Within physical therapy, a basic understanding of behavioral theory can assist in patient assessment. Patient education for health behavior change can be enhanced through a better understanding of the patient's perspectives, including his or her perceptions regarding the importance of the recommended change, his or her level of confidence in making the change, and how ready he or she is to initiate that change. Readiness to change is a key component of the Transtheoretical model of human behavior. According to this model, there are 5 stages involved in behavior change. In the first stage, pre-contemplation, the individual is not planning or considering any type of change in behavior within the next 6 months. He or she may not even be aware that a change is recommended or encouraged. During the next phase, contemplation, there is an awareness of a possible need and/or potential benefit of health behavior change. The individual is considering whether to make this change at some point within the next 6 months. Once the decision to change one's behavior has been made, the individual may start to gather necessary information and/or resources. Getting ready to change within the next 30 days is what happens during the preparation stage. Once the new behavior is initiated, the first 6 months are called the action stage. After 6 months, when new habits have been successfully established, the individual is said to be in the maintenance phase. The diagram shown here draws an association between prevailing attitudes in each stage of change. In pre-contemplation, the person may either think that he or she can't do it, or they may simply refuse to change. That is, I won't do it. If something inspires the person to reconsider, he or she may start to wonder how to start working towards the goal. Information and suggestions from the PT and PTA can help increase motivation so that the person decides to try. An action plan with distinct goals can help an individual track incremental success, building self-confidence and the ability to succeed. Through persistence, short-term goals become long-term outcomes until finally the person can celebrate their achievements by saying, "Yes, I did it." Despite the stepwise progression depicted in the last diagram, progress through the stages of change are not necessarily linear. People can and often do revert to earlier stages in the process. Maybe a patient wants to start a new exercise program and starts with something that is too strenuous. An injury or excessive soreness can cause the person to lose confidence or begin to question the value of their new routine. Although this person had been in the action phase, he or she may revert back to pre-contemplation. People also commonly experience lapses and relapses in behavior. A lapse is a temporary return to former behaviors. For example, someone with a healthy diet may go out to dinner, see a tempting dessert on the menu, and overindulge. If he or she returns to a healthy diet the next morning, this would be described as a lapse. If poor eating patterns continue over days or weeks, the behavior would be considered a relapse. It is very important to advise patients that lapses are a normal part of change. Each lapse can be used as a learning activity. A lapse often occurs because there wasn't an effective plan in place to manage the challenge. Using motivational interviewing techniques, the PT or PTA can help the patient review the circumstances, identify the challenge, and consider better ways to manage this in the future in order to support the desired behavior and avoid additional lapses or a relapse. Motivational interviewing techniques can also be used to assess the patient's readiness to change. The PT or PTA can assess the patient's starting point by asking an open-ended question like this. On a scale from 0 to 10, where 10 represents the highest level of motivation, how prepared are you to begin a home exercise program? If the patient gives a low number, like a 3 or a 4, Follow-up questions could help determine the types of factors or circumstances that could raise the patient's level of motivation. Conversely, when someone gives a high rating on the 0 to 10 scale, the PT or PTA could ask about the factors or circumstances that inspire that high degree of commitment. Speaking about positive factors that contribute to the desire or commitment to change can often strengthen motivation. At its core, motivational interviewing is a tailored, patient-centered approach based upon the individual's goals, confidence level, and perceptions. It is a technique that fosters open communication, which is a hallmark of expert practice in physical therapy. Open communication enables a better understanding of the full scope of contextual factors that influence limitations in function. This includes the patient's personal values, as well as any additional social or psychological factors that should also be considered. The use of a patient-centered approach to promoting changes in health behavior demonstrates respect for the individual's level of autonomy. It is associated with increased patient satisfaction and improved levels of adherence. It allows the physical therapist and physical therapist assistant to tailor the approach to patient education by encouraging the patient to explore and resolve ambivalence to change by weighing the pros and cons of the desired behavior. Deliberate focus on the possibility and likelihood of desired outcomes can promote positive decisional balance. PTs and PTAs often have unique opportunities to plan and implement patient-centered approaches to health behavior change. Illness, injury, or the onset of new physical impairments can act as teachable moments by calling attention to the negative consequences of certain lifestyle factors, such as being sedentary or not eating properly. Patient evaluation and baseline measurements can help track progress or demonstrate the need for change, thereby enhancing the patient's motivation. This would include measurements of cardiovascular fitness, pulmonary function, strength, and/or endurance. In the third and final section of this course, we are going to use the factors that we have just discussed, including health behavior change theories, to cover practical strategies that are utilized during motivational interviewing.